We have two incredible presentations for you this evening on palliative care support for primary care and the information that many are seeking about the respiratory vaccine rollout. So just our normal housekeeping that we do at this meeting, please stay on mute if you're not speaking. We will be watching for the raise hand feature to ask a question. The chat is available to everyone. And if you are signed in as iPhone, if you could please use the feature to hit rename and add your name so that we can keep track of your main pro credits. And of course, if you haven't already, please be sure to sign up for the London Middlesex Primary Care Alliance newsletter and stay informed on what we're up to. And of course, in case you weren't aware, this is who we are. We're the London Middlesex Primary Care Alliance right now, and we're in the process of transforming into the Middlesex London Primary Care Network. So stay tuned for that. And we're here to support primary care. All right, so our first speakers today are going to be Andrea Wappet and Carina Jacob. They're palliative pain symptom management consultants. And that role is mandated nursing position by the Ministry of Health and Long-Term Care throughout Ontario. In London Middlesex, this role is situated within St. Joseph's Healthcare, serving Southwestern Ontario and Erie St. Clair area. And the PPSMCs offer secondary level hospice palliative care expertise through a range of services, including consultation, collaboration, facilitation, and education. And they play a critical role in enhancing palliative care capacity across various settings, working with healthcare professionals through both formal education and initiatives. And they're going to tell you all about this role and some tools that they have. And at this time, I'm going to go ahead and introduce Dr. Joanne Kearon as well, because we're going to flow through the first presentation and your questions, and then flow right into the second presentation and questions. But we'll just get the introductions out of the way. Dr. Joanne Kearon is the Associate Medical Officer of Health for the Middlesex London Health Unit. In her role, she provides medical oversight to vaccine preventable disease programming and champions the importance of vaccines and vaccination for a healthy community. Dr. Kearon holds a Bachelor and Master of Science from Queen's University and a Doctor of Medicine, a Master of Public Health, as well as completing residencies in family medicine and public health and preventative medicine from McMaster University. And we feel very honored to have these speakers with us today. It's a compelling program, and we're glad that you're all here. So with that, we are going to flow right into the palliative portion, and the objectives are stated here, and you saw those on our poster. So we're going to stop sharing this and let our speakers go ahead and share their own presentation.
All right, thank you so much. So excited, I'll just share my screen here. All right, hi there, everyone. Thank you so much for having us. My name's Carina, and I'm here with my colleague, Andrea, and we are here representing the Palliative Pain and Symptom Management Consultation Program. So I'll just tell you a little bit more about that. Just quickly, tonight we're just going to understand the role of what we do, what a palliative pain and symptom management consultant does. We're going to look at some of our educational offerings, and we're also going to look at a specific resource that we'd like to share with you in primary care. So I'm just going to move on to the next screen here. So in our little introduction there, some of this has already been covered, but just in terms of our role in the province, we are part of a network of palliative pain and symptom management consultants, or PPSMCs for short, across Ontario. So there's consultants that work in every region. So in the Southwest, we have consultants that represent 6 regions. We're funded by the provincial government. And in the Southwest, we're employed through St. Joseph's Healthcare London, so our main office is in the Parkwood Institute building. So nationally, our work is guided by the Model to Guide Hospice Palliative Care, which is a document that was developed by the Canadian Hospice Palliative Care Association. And also provincially, our work is guided by the Ontario Palliative Care Network, or the OPCN. So both provide direction in the development of services and standards to improve care throughout the illness trajectory. Just a little bit more about that Model to Guide Hospice Palliative Care. So this diagram comes from that Model to Guide Hospice Palliative Care document. And basically it's what we consider the ideal of the palliative approach. Ideally, so what you're looking at here is sort of the focus of care on the vertical and time on the horizontal. So, and what we see at the very beginning here is the presentation or diagnosis of a life-limiting illness. So ideally, that palliative care approach really begins at the presentation or diagnosis of a life-limiting illness, a serious illness. And this really does challenge that prevailing understanding within our society that palliative care is really only about end of life. So we really espouse a much broader definition of palliative care. So, part of our work is definitely challenging that and kind of giving sort of the pitch about promoting that early identification of palliative needs and that early integration of the palliative approach, which partly is why we're here today, because primary care has a big role within that. So with that early integration, palliative care can exist alongside disease modifying therapy, or it can be the sole focus of care, and it should continue throughout the illness trajectory into that bereavement period for those affected by the death of a loved one. So just thinking about a really broad understanding of that palliative care approach to really include basically the entire illness trajectory as well as that bereavement period. Okay. And just again, going back to that OPCN in the province, so there is a document called the Health Services Delivery Framework that I'm sure some or all of you are familiar with, but basically the goal is to enable patients to remain home as long as possible, reduce unnecessary hospitalizations, and improve overall coordination and quality of palliative care in Ontario. So in terms of our role, so the PPSMC, so our goal and our mandate is to build capacity of providers in the community in the provision of quality hospice palliative care. So we educate and support frontline providers who are providing a palliative approach in the community. And that can be anyone. So who do we support? We really support any member of the interprofessional team in any setting. So it could be, any provider that's located in a primary care setting. In terms of the support that we offer, we do some consultation. We do a lot of education and mentorship, and we also sort of collate and find palliative care resources. So if there's a specific area that someone was looking for a good resource on, we would certainly do the work to get that and to curate that for you. In terms of, so what does that actually look like? What does our support look like? So we do some formal courses. I'm not going to talk about all of them because Andrea is going to cover a couple of them, but just for some of the more caregiver focused one or care provider focused ones, we have what we call fundamentals of hospice palliative care. So that could be anyone from a volunteer in palliative care all the way up to a physician. It doesn't matter. It's really a foundational understanding of what that hospice palliative care approach is. So that's one of our courses. Then we also have Comprehensive Advanced Palliative Care Education, or CAPC. This is an advanced course for nurses in palliative care, and it really has a clinical focus. And then we also have a course called Essentials of Pain Management. And again, it's a palliative course, but it focuses specifically on pain management, and it's for nurses as well. And then Andrea's going to talk about the rest of the courses as well as the events, but we do hold some events as part of our program to get the word out and to further the education of all kinds of providers in the community. We also provide individualized support. So if a particular program, for instance, we go into long-term care a lot of the time, so we would assist in developing and reaching goals of a palliative program. We can do more tailored in-services on any topic related to palliative care. So an example would be if someone wanted a pain presentation or a presentation on what care looks like at end of life, we could certainly do things like that. Again, we research and compile general palliative resources, and we provide that one-on-one secondary level consultation and mentorship. Let's talk a little bit more about what that means on this slide here. So consultation. So we do provide consultation to frontline health providers, and it could be about a specific situation, like a specific case that there's questions about, or just even a common situation that comes up. We do tend to address pain and symptom management, but we can assist with anything palliative care related in any domain, whether it's bringing in an interprofessional team member or looking for resources for that. So the purpose is to coach and mentor by providing evidence-based recommendations, which will then enhance that provider's capacity to continue to provide quality palliative care. So we're not going in and necessarily, so it's not a consultation in the sense that we're assessing the patient necessarily directly, but we would get an overall understanding of what was going on with that person and give some recommendations to that frontline provider, and they can follow up on those recommendations and decide what makes the most sense in that situation. So again, just to build that person's capacity. All right, I'm going to pass it over to, or I'm going to keep doing the slides, but Andrea is going to continue chatting with you with this next slide.
Perfect. Thanks, Carina. So I'm going to talk a little bit about some of the education that we provide that might be, interesting to primary care, to physicians, nurse practitioners, or other staff as well. So first of all, we have our In the Know Palliative Education series. It's a free virtual offering that we do once a month at lunchtime. We bring in different experts to talk about different topics in palliative care. This is the third year that we've ran this program. So the expert will usually talk about a certain topic, and then at the end, there's usually an opportunity to ask questions, which everybody usually quite enjoys to be able to get their burning questions answered. For those that aren't able to attend, there is a recording that we email out with the resources that the expert may have spoken about. So that's usually sent out after the presentation. And there are past recordings and resources available on our website as well. So I do have a QR code up there, and you'll see that for some of the topics that we have up here. If you want to use the QR code, it'll take you directly so that you can register. You can register for all the upcoming ones, and then you'll just be sent the recordings if you're unable to attend. I'm not going to go over all of the upcoming ones, but just coming up November 13th, we have Dr. Kelly Fenn, who's a palliative physician in Grey Bruce, and she's also a coroner, so she's coming to talk about the role of the coroner as well. And then again, you can have a look and see what else is coming up in the next few months. Okay, next slide, Carina. So the next one I wanted to chat about was the Canadian Serious Illness Conversation Training. This may be something that you have heard about, something that is definitely been out there quite a lot lately. There is CME credits for this course, and Pallium is offering it free of charge currently. It was developed by Harvard. It is a course that has 1 to 2 hours of independent work online, and then 2 hours of class time, which can either be virtual or in person. The guide that they use, the Serious Illness Conversation Guide, it has been researched and developed using patient-tested language. And it also has been researched regarding sort of the flow of that conversation, and the guide sort of walks you through the flow of having a serious illness conversation with a patient or family. Also included in that, 2 hours of class time, we do talk about sort of practical tools, and we discuss how to incorporate this into something that might interest you. Again, the QR code is there. We do have some dates up on our that are available right now. If you're not finding anything, please reach out to us. We will be having more availability. They have been filling up fairly quickly. Okay, and I'll go to the next slide then, Carina. The next one is our Physician Education Day. So it's the West Region Palliative Care Education Day. We held it last April, and I'll talk more about that, but this will be our second year coming up, April 10th, 2025. It is a half day, it is virtual, so it's from 8 until 1. This year we're going to be, our topic is living and dying with non-malignant illness, optimizing symptoms and medication management. We do have a few speakers secured so far, a palliative physician, a pharmacist, and we're hoping as well to have another physician that focuses more on neurodegenerative disease. So just waiting to confirm all of that. But our topics are going to include symptom management for those non-malignant illnesses, specifically kidney and liver disease, and then also, as I mentioned, neurodegenerative disease. The pharmacist is going to talk more about deprescribing and end-of-life order sets, and hoping as well to focus on the symptom response kits in the community and how to use those kits to help manage symptoms for these patients. So registration will be available on our website in the new year. As I said, we're just trying to confirm everything and get our speakers confirmed, and then we will have registration available. So our website is there if you're interested in that. Okay, we'll move on. I'm sure also of you have heard about the LEAP programs that are offered through Pallium Canada. Both Carina and I do facilitate LEAP courses. There are quite a few different ones. We've done LEAP Paramedicine and LEAP Long-Term Care, LEAP Home Care. There is a LEAP Core course and a LEAP Mini course as well. All sort of have the same type of information. Some are a little more in-depth. They can be available either virtual or in person. When we run the sessions with physicians as learners, we do usually have a physician who supports facilitating during those sessions as well. So they sometimes dig a little bit more deeper into, more complex situations or discuss prescribing more in depth. If you are interested in a LEAP course, we are looking to arrange one for the new year, hopefully in person, but please feel free to reach out to us if you're interested in something like that. And there are CME credits involved with that as well. Okay, we'll move on to the next. Okay, so I wanted to chat a little bit about a resource that we have that we're quite excited about. Some of you might be familiar with the Pallium Palliative Pocketbook, which is that first picture there. And that really is the gold standard reference for palliative care. And a reference that we definitely used as I kind of talk more about what we've created here. The second picture there is the Palliative Pain and Symptom Management Pocket Reference Guide. This was developed quite a long time ago. I don't know if it's familiar to some of you. The last edition for it was in 2009, and it was created to provide some general palliative care information for physicians and registered nurses that did have some palliative care expertise. And the third picture that we have up there is our new guide. So at our West Region Palliative Care Education Day last year, we launched a new palliative pocket guide that was edited and updated to reflect 2024 best practices. We had the assistance of a few consulting physicians and 2 med students from Western that helped us with doing the update and editing of the guide. You can go to the next slide, Carina. So some of the reason why we came up with this, we found that primary health teams were one care setting that we don't reach very often, unfortunately. And so we thought that if we had a better resource or some tools that that might be helpful to support your teams better. So we came up with the Education Day, which we're hoping to do on an annual basis. And bringing in speakers that would interest you. And then also, we decided to create this palliative pocket reference guide for you as well. So we did bring in palliative care expert physicians from each of our geographies. So we talked about across the Southwest. So you'll see on the screen there at the bottom are the past members and contributors to the guide that was last edited in 2009. And then on the top is the consultant team from our new guide for 2024. And I'm sure you'll recognize some of the names on there. Okay, so we'll move on to the next one, Carina. So as I mentioned, our goal was really to reflect best practices in 2024. We wanted to make it accessible to everyone. So you'll see the old guide was just a printed version. We wanted it to be more available and cover more topics. So, not just for, people that already had some palliative care experience or expertise. We wanted it to be for all general practitioners. So that more content and topics were added to the pocketbook as well. Some common abbreviations and assessment tools were added, and we do have printed copies available. You can reach out to either Carina and I, and we can get those in your hands. But there's also an online version that not only can you look at on a laptop, but it also looks great on a cell phone if you're pulling it up on the go. So both versions are easy to access. It is meant to be a quick reference. We've tried to keep it as concise as possible. We've included in it common billing codes. We do use QR codes throughout, and we do have some links to some other references as well. We also direct users to more information. So it's not just the information within the guides, but those QR codes and links do take you to maybe some other education or some other guidance that might help you as well. And then we also have the QR code on the back, which is to our website to direct you to some more palliative care education there. Okay, so yes, this just kind of gives you a quick glimpse at the layout of the guide. So like I said, we try to keep it really concise and easy to read. So this is just a look at the paper copy and what that might look like with the QR codes on there. There was a lot of requests for a paper copy. A lot of our palliative care consultants that were part of the committee felt that that was needed. So as I said, we do have those, but it is also available online. And maybe if you don't mind, Carina, if you want to just stop sharing for a minute, I will share my screen. I just want to give you a quick look at the online version as well. Okay, so this is what you land on when you get to our website. And if you look at the top, it says reference guide here. And if you click on that, it takes you right to the actual reference guide. I'm just going to scroll down. I don't want to make anybody feel sick by scrolling, but just to give you an idea, I'm going to scroll quickly for a second here. That's the listing of everybody that was involved. As we get to the index, all of the index, you can click on different links to get to things quite quickly, which is helpful when you're trying to find a specific topic. I'm going to scroll down a little bit more here. I apologize. I just wanted to show you as well, if you found a topic, just kind of show you what that looks like. So it's going to take you right to the specific topic, and to give you really concise information on that topic, and then take you to other links. So there is the electronic death certificate. So there's a QR code that you can use to get there as well, or you can click on the link and that will take you there. So we've tried to make it as easy to navigate as possible. I definitely wasn't part of the IT side of things, but I do think it does work quite well. And I would show you on a cell phone, but it does show up quite nicely on there as well. Okay, Carina, are you able to share your screen again just for the last couple of slides? Perfect. You can go on to the next one. Great. So finally, I just wanted to say that we do send out a monthly email. We keep it to once a month, I promise. And it's just, we send out some educational opportunities and resources. They might not all apply to you because we do send them to lots of different settings and the interprofessional team. But if you would like to be part of that mailing list, we will post things like upcoming serious illness or LEAP opportunities. Those types of things are always part of our newsletter. And also some of the resources that we share you might find interesting as well. So I did put a QR code there. If you want to join our mailing list, you can just use that QR code and add your name, and we'll make sure to add you to our list to send that out to you. And then finally, just the last slide, Carina. Just our contact information. So you have that available as well, but Carina and my contacts, both email and cell phone numbers, and then our website. And thank you very much for having us. And I guess if you have any questions, we're here hopefully to answer those for you.
Yeah, wow, that was amazing. That's so, it's as a person that's had family members in palliative care some years ago, it's incredible to see how much this has grown and what's available now. That's just amazing. And I've taken down all this information too as we move towards our new primary care network structure and all the resources we want to have available in the new improved organization. So I've taken all that information down. How do I see more of who's got hands up here, Dahlia? Perfect. So we open this up to questions for Carina and Andrea. I see that we've got some things in the chat. So maybe I'll move to Vineet. Did you want to, have you been monitoring the chat for us?
Sorry, my voice is terrible today. But overall, no, just there's a lot of comments of how great the guide looks. It really does look very user-friendly, very practical, very to the point and concise. That's really looks great. Thanks so much.
Yeah, absolutely incredible. And any other questions from those that have joined us live? And then we know that there's a number of people are going to be watching the recording. Okay, I guess we'll move on then, and we'll thank you again so much for that, sharing your resources and letting us know about the palliative supports and your roles. So that's absolutely incredible. So next we'll move to Dr. Joanne Kearon, who is here with the fall vaccination program and to answer all of your questions about that. So Joanne, I believe we've shared with you the ability to share your screen and bring your slides up.
Are you able to see that?
We see you.
Let me see.
So there you are. I think it's happening. Yep.
Now
You're
it's
good.
working? Okay.
Yeah.
Just a second. Okay. Hi, everyone. Thank you for having me today. So I wanted to bring a little bit of information around the vaccine rollout. I expect you may have a bunch of questions. Happy to answer those as well. I wanted to talk first of all a little bit about the epidemiology. You can't really have a talk from a public health physician without first going through some epidemiology and statistics. And then I'll talk a little bit about the specific vaccine products for this season. And finally, talk a little bit about vaccine rates, what we're expecting, and how we can potentially try to increase vaccine rates this year. So first of all, an overview of previous seasons and what we saw through the pandemic. So obviously with COVID-19, you see 2020, 2021, 2022, like that huge spike in cases that we all experienced with wave after wave of different variants of COVID-19. What you see now is that the number of cases has decreased significantly, and that is because we aren't testing. Our strategy now is test to treat. So we, rats aren't even widely available. It really is just if you're considering treating someone that you would decide to test them. So we would expect that the number of cases has decreased last year, but you also notice that the number of deaths as well as the number of outbreaks, the number of hospitalizations, those have decreased as well for COVID-19, and we're continuing to see that decrease this year. And that's related to the immunity that people have now from both vaccination as well as natural immunity from being infected once or multiple times. Influenza, interestingly, because of everything that we were doing for COVID-19, also being effective for flu, during the pandemic, we actually saw influenza cases drop to, in one of the years, to nothing. We didn't identify any cases of influenza in that year, as well as the deaths decreasing as well. What we saw last year is basically a return to a normal flu season. So last year was a normal flu season, and that's what we're expecting this year as well. These are the outbreaks that we had over this past year in institutions, so long-term care homes, retirement homes, and hospitals. The bulk of them remained COVID-19 over this past year. Over the course of a year pre-pandemic, what we would normally have seen is basically no outbreaks related to respiratory viruses through the summer months at all. We would have seen a complete drop to zero. We didn't see that this year. COVID-19 activity continued throughout, but also because we were testing so much, we found other viruses as well, causing really mild symptoms. So part of that is that COVID-19 activity did continue all throughout the summer this past year, but part of it also is that post-pandemic, our expectations for testing and our sensitivity for, or our threshold for testing has decreased, and so we are testing much more, and our screening for residents and what we would constitute a symptom and leading to isolation, things like that, has reduced. And so we here at the health unit stayed quite busy this summer with outbreaks. In terms of hospitalizations and deaths, we did see a decrease over the course of the summer related to COVID-19, which is great. We have seen a bit of a increase over the last few weeks, but certainly not to where it was last year, and certainly not to years before that, again, representing that immunity is building. This is a graph of influenza cases over several years, basically representing that last year was a return to a very typical influenza season. So key takeaways from our EPI in terms of the context for which we're engaging in a respiratory vaccination season is last year was a relatively normal influenza season. It continued to be dominated by COVID-19, and COVID-19 outbreaks continued throughout the summer. What we're expecting for this coming year is that COVID-19 will continue to predominate, though likely decreased from last year, as well as decreased severe outcomes. Respiratory season has been declared, so it's happening right now. Just in the last couple weeks, we have declared that we're locally in a high-risk transmission period. Mixed outbreaks are expected throughout the year, and that it would be a relatively normal influenza season. Our respiratory dashboard is back. We did take it down earlier this year related to changes in what data would be available to us, but it is back up and we update it every week on Tuesdays. And as I said, just last week, we did change our risk assessment to us being locally in a high risk period for respiratory illness. So vaccine coverage last year. COVID-19 and influenza vaccines were offered around the same time. COVID-19 vaccine had high uptake at the beginning of the pandemic. There were vaccine mandates. Severe illness was very apparent. So people definitely felt the need to be vaccinated. Subsequent doses, we have seen decreased vaccination rate with each subsequent campaign. Individuals greater than 65 years have the highest uptake of both vaccines, and that is typical from pre-pandemic. That influenza, it would have been similar, that people who are older than 65, because they are the highest risk, they know they are the highest risk, and we as healthcare providers put the most effort in trying to reach that population, they do have the highest uptake, which is really what we are trying to get. Most people, if they're going to receive both vaccines, it's because they're going to receive them at the same time. So there's definitely that piece around convenience that if they're there to get one, we really would like to vaccinate them for both. And this year, RSV and pneumococcal vaccines are part of the overall plan for optimal protection for respiratory illness. This is the vaccination rates across Ontario for COVID-19. And so really seeing that vaccination rates did decrease with each subsequent dose that was being released. And then this is compared to influenza. This is specifically for healthcare workers in long-term care homes and hospitals, and how it has trended over the years. There are years when the uptake is lower. Sometimes it's related to messages around, oh, it's not a good match year. We saw an increase in vaccination rates for influenza during the pandemic, but that has actually drastically dropped because we are seeing what we would term vaccine fatigue, and that people are starting to question every single vaccine that they are being offered. So the recommendations for vaccines this coming year, while respiratory viruses circulate year-round, it is respiratory season. Respiratory season would typically be considered the beginning of November to the end of March, though there is some variation regarding what we see locally. And so, as I said, we are now in a high risk period. The vaccine campaign this year focuses on influenza, COVID-19, and RSV. We take our recommendations from NACI, as well as NACI informing the whole system of vaccination and the recommendations and eligibility criteria set by the province. But NACI remains what we certainly at MLHU look to for guidance. So I wanted to pull out a couple key statements from NACI regarding the vaccines. And I mean, each piece of guidance that NACI gives on any of these vaccines is quite lengthy, usually with a number of recommendations, with differences on the strength of recommendation, whether it's discretionary or strongly recommended. But I just wanted to pull out a couple pieces. So influenza, this is their typical guidance for influenza, is that it is recommended for everyone annually and that it should be offered to anyone who is 6 months of age and older, who doesn't have a contraindication to the vaccine. And that is a strong recommendation. The way that they word it, though, is, as it says there, is it should be offered. They have a separate recommendation for influenza for those who are high risk, which does state strong recommendation, really saying that, like, for those individuals, which again is older than 65, immunocompromised, who are at higher risk of severe outcomes from influenza, we really want to do that push to get that population vaccinated. For COVID-19, their recommendations generally are starting to align with influenza, and so their list of who is considered high risk is starting to align for both influenza and COVID-19. Their phrasing for the for those who are at higher risk is that it is strongly recommended for previously vaccinated and unvaccinated individuals at increased risk of infection or severe COVID-19 disease. And then for everyone else, aligning more with influenza and how it's phrased there is that all others 6 months of age and older who are not at increased risk may receive. And so it is a lot more discretionary. And when they look at the evidence, they do say that it is based on more discretionary guidance. For RSV, specifically for the infant population, they recommend building towards a universal RSV immunization program for all infants, and that they recommend RSV immunization programs use nirsevimab or Beyfortus to prevent severe RSV disease. So they are recommending that this actually be, and this is going to be our first year doing it, but we are really trying to move towards every single infant being vaccinated for RSV, because we know that infants are the highest risk for severe outcomes from RSV. Last year was our first time vaccinating the elderly population, and certainly certain people within that population would be at higher risk for severe outcomes. But by and large, we don't see a large amount of hospitalization in the older than 65 years related to RSV. For RSV, the population that is most at risk really are the newborns. And so we do want to reach a place where we're able to confidently say that we're vaccinating everyone. For the older adults, they do say that it is recommended for those who are 75 years of age and older, particularly for those who are at increased risk of severe disease, as well as being recommended for those who are 65 years of age and older who live in congregate settings due to the risk of outbreaks. And then for those who are not in congregate settings and not in at increased risk of severe disease, it is more discretionary guidance, which is why Ontario, when looking at their entire campaign and the eligibility criteria, it's not publicly funded for that group. So everything's available now. As of just yesterday, the province did announce that influenza and COVID-19 is available for the general population. So over the last few weeks, we've been vaccinating the high-risk individuals, and so now we are moving to the general population, and so it is generally available. RSV is available now, particularly for adults, pregnant women. For infants, we are still working through some distribution challenges from the province for all doses, but the availability for RSV immunization is increasing. And then pneumococcal vaccines remain available ongoing. In order to try to promote influenza and COVID-19 vaccine administration, given the fact that, as I said, evidence shows that if someone's going to get vaccinated with them both, it's because they're going to get it done on the same day. They've tried to align the campaigns as much as possible. So the high-risk criteria has been aligned for both vaccines in most categories. The vaccine campaigns have been timed to happen at the same time. They were hoping to get more alignment with the RSV campaign as well, but some challenges there as it is the first year with that product. But certainly COVID-19 and influenza have been aligned in terms of timing. The vaccines are available for ordering and dose administration at the same time. And COVID-19 vaccine dosing is 1 dose for most individuals, which once again aligns with influenza. For influenza vaccine, we have a number of products available. The coverage of strains is 2A and 2B for the QIVs, and then the QIV high dose and the TIV with adjuvant for those who are older than 65 years of age. We have 2 products available. The TIV does not have the Yamagata lineage. This is a reminder, though, that if the high dose or the adjuvanted is not available at any given point in time, we don't recommend waiting for that vaccine because we may not know when that vaccine is going to be available and you'll be able to order more. So if you have only one of the other products available, and you have somebody coming into your office, definitely take that opportunity and vaccinate them with one of the other vaccines. The other thing is that the Flucelvax quad is egg-free for anyone who is specifically requesting that, and so you may have heard some coverage of that. There's been some discussion. However, NACI continues to state that for all of the other vaccines, that's not actually a contraindication to receiving. So if somebody says that they have egg allergy, even though the Flucelvax is explicitly egg-free, an egg allergy isn't actually a contraindication for any of the other vaccines. The priority populations, and even though I said that it is now generally available, it's open to the general population, these really are the groups of people that we are trying to get higher rates of vaccination for their individual protection. So first of all, individuals with significant exposure to birds or mammals is because of the concern around avian influenza that we have seen that coming up from the States, and it's now been identified in several bird populations here in Canada, and they have seen in the States evidence of transmission to humans. So it is something that we are watching, and so because of that, it has been prioritized for influenza vaccination, and simply for alignment, they've included that for COVID-19 as well. Those who are at higher risk, whether that's because they're immunocompromised or otherwise, healthcare workers, first responders, people over the age of 65, those in congregate living settings, and that's partly to reduce the risk of outbreaks, individuals in or from First Nations, Métis, or Inuit communities, members of racialized or other equity deserving communities, pregnant women, children 6 months to 4 years of age, and individuals 6 months of age and older with underlying health conditions. Once now that it has been opened up to the public, they have listed out a number of people who we also want to try to reach, partly to protect that earlier list of people who are priorities. So anyone who is providing care to children, anyone who is providing care within their household, or working within these settings. The COVID-19 vaccine products, so Moderna and Pfizer, are both available, although we are trying to get away from phrasing it like that and saying to people, oh, you're receiving Pfizer, oh, you're receiving Moderna. The message much more is that it's an mRNA vaccine, and that is the technology that is used to create the vaccine, and that the safety information for Moderna and Pfizer are the same. The actual Moderna is the one that is available for those who are 6 months to 11 years, while Pfizer is approved for 12 years and older. The Moderna does require reconstitution, while Pfizer does not. It has been updated with the KP.2 strain, which is what we are expecting to be most prevalent based off of epidemiology and other areas. It wasn't the most prevalent in the last month, but we are actually seeing the KP.2 strain increase. So it is what's expected to be most prevalent this season. I am expecting that next year and moving forward, this will be similar to flu. Every year we look at what's happening around the world, we look at what strains are prevalent, and then we forecast and base what strain the vaccine is updated for based on that. Now moving to RSV, the new product. So Abrysvo was the product last year, and that is for 1 day dose over the age of 60 for high-risk populations. Arexvy, maybe it was Arexvy that was last year. That's also for 1 dose over the age of 60 for high-risk populations. However, it also has been now approved to be given during pregnancy for those who are 32 to 36 weeks gestation, who are expected to deliver within the RSV season, and that is to provide passive immunity for the infant. Immunity for the infant from Arexvy is expected to be about 6 months because it is still passive immunity. Nirsevimab, on the other hand, or brand name is Beyfortus, is actually not a vaccine, although by all accounts, in terms of how it's stored, how it's used and given, and how long you need to monitor for them after you give it, things like that, it functions as a vaccine. However, it is a passive immunization. So it is a monoclonal antibody, and it gives passive immunity for the infant. It similarly then gives about 6 months of immunity. And so we recommend that infants, for the purpose of infant protection, you give the Arexvy or nirsevimab shortly before or during the RSV season, compared to Abrysvo and Arexvy for the older population. It's not clear how long that actually gives people protection for. They are actually expecting that for Abrysvo and Arexvy for the older adults may give longer lasting protection, and so that we don't need to revaccinate people year by year. So everyone who was vaccinated last year as part of the older adult campaign do not need to be revaccinated again this year with Abrysvo or Arexvy. The recommendation between Arexvy and Beyfortus is that the infant would receive Beyfortus. So if it is a choice between one or the other, we would recommend Beyfortus. However, if for some reason the parents are not comfortable with that and they would prefer to be the one to receive the vaccine, then you can give Arexvy between 32 to 36 weeks gestation. Just in terms of what we are going to be doing here at MLHU, we are no longer providing mass clinics. We are providing mobile clinics for priority populations, for equity deserving populations. We are continuing to do our job in terms of distribution and getting the vaccines out to hospitals, long-term care homes, retirement homes, and out to you as healthcare providers. We are going to be holding bi-weekly clinics specifically for those who are under 2 years of age. Pharmacies do have both COVID-19 and influenza. Most are providing both. Many will provide vaccination to children over the age of 2. There are some that cut the limit off at 5, and so we do recommend that individuals call and make sure that their pharmacy will actually provide it to their child and make an appointment that way. However, I don't believe any pharmacists are able to give it under the age of 2, and so we are providing vaccination to that age group for COVID-19. If we have them here for COVID-19, we will opportunistically also do influenza and RSV and do the nirsevimab Beyfortus immunization. However, it is primarily a COVID-19 clinic, and so we are not providing Beyfortus for Beyfortus clinics alone, immunizations alone. So if someone is looking for Beyfortus for their child, but not looking for COVID-19, they would not actually be able to book an appointment here at MLHU. LHSC is, I believe we'll get into that. Okay, I'll come back to that. In terms of our activities, we are also assisting retirement homes with the adult immunization campaign as needed. So in terms of where to tell your your patients to get vaccinated, as I said, 6 months to 2 years, you can send them to us for COVID-19 if they aren't, if you aren't providing COVID-19 or influenza, they can make an appointment here. For RSV, if they are not looking for COVID-19, as I said, we are asking that you provide that immunization. It is available to order off of FOSS. We have resources online about how and when to provide the Beyfortus. LHSC is running a clinic for specifically Beyfortus to immunize newborns. However, they are immunizing primarily newborns who are born in hospital or who do not have a healthcare provider at all. So if people call us and they don't have a family doctor, we are referring them to the LHSC clinic. However, if they do have a family doctor, we are referring them back to their healthcare provider. For individuals 2 to 18 years of age, most people will likely get vaccinated at pharmacies, so you can refer them to the pharmacies, although we continue to encourage you to provide vaccination. And if you have any questions, I know that there are some barriers around COVID-19, but if you are interested in signing up for COVAX-On and providing COVID-19, please be in touch. And then adults, again, will primarily be in pharmacies, and we will be helping with the vaccination of long-term care homes and retirement homes. We are creating tear-off pads that have a list of where people can go for vaccination. So you can order those on FOSS, on the public health ordering system, and provide those to your patients so that you can give them direction about who they can ask about getting vaccinated. So I just want to end off with a little bit of discussion of increasing vaccination rates. So the most common reason for getting the flu shot was to prevent infection. Whereas the most common reason for not getting the flu shot was the perception that the vaccine was not needed. So that's definitely good information for us when we're trying to have conversations with patients in terms of gauging their understanding of risk. The most common reason for not receiving a COVID-19 vaccine last year was concerns about the safety or side effects. So again, having those conversations to provide factual information about safety and risk. When we look at the spectrum of vaccine hesitancy, it can sometimes feel like that there's been a large rise in vaccine hesitancy, but the research would actually show that it is in the minority. And most people, if offered a vaccine and it's convenient to get and they have an ability to get their questions answered, would be willing to get vaccinated. Certainly to a level that would provide us herd immunity. And so when we are seeing the vaccine fatigue, there's a lot of reasons for that, and it's not only, there's certainly been a rise in vaccine hesitancy, but certainly not insurmountable. In terms of increasing vaccine acceptance, what we call the 5 C's is we want to increase confidence in the vaccine, and decrease complacency, so making sure that people understand that the risk of illness is real, and the risk of severe illness is real, even for some younger populations. We want to, as much as possible, increase convenience, increase a sense of collective responsibility, and maximize our communication mechanisms, and then address some elements of context and culture. So in terms of increasing confidence, here at the health unit, we are certainly trying to put out messages that emphasize the effectiveness of vaccines. We do hear from people that where do you go? If we were to ask, where do you go for your vaccine information? Their primary healthcare provider continues to be one of their main sources of trusted information. And so we want to still be able to have one-to-one conversations around transparency of immunization side effects and safety profile, and provide that factual scientific information. For increasing convenience, we want to increase access to vaccination, and certainly we have to acknowledge that the context for this is much different than during the pandemic. So certainly from MLHU side, where we used to be able to provide mass clinics, the convenience or the accessibility has decreased. But that's why we want to make it as clear as possible for individuals about where they can go for vaccination, and to decrease barriers to getting vaccinated. To change the context, we are trying to provide messages that everyone is getting vaccinated, that it's a normal thing to do. And certainly in our equity deserving communities, we are working with community leaders in those targeted populations where we know that vaccine rates are historically lower. In terms of decreasing complacency, we are trying to have some messages that emphasize the seriousness of illness. However, this has to be modulated by the fact that we know that NACI's recommendations have changed, that the context has changed. And like I had said, with all of the epi, we are seeing decreased serious events from COVID-19 related to increasing herd immunity from both vaccination and natural immunity from infection. With that said, we can lose herd immunity, and we may at some point, depending on the variant, see increases in serious outcomes from that. And so it is something that we continue to try to have a nuanced message for. In terms of decreasing complacency, one method that I do want to highlight, though, is reminders. And this is something that you can certainly help us as healthcare providers, is that even if you, for example, are not personally providing COVID-19 vaccine, sending reminders to your patients to get vaccinated and telling them where they can get vaccinated is helpful to remind people that it's that time of year again. And then finally, encouraging collective responsibility. There is evidence to show that workplace immunization policies, and this is particularly important for long-term care homes and hospitals, that immunization policies do increase vaccination rates. And lastly, just some reputable sources, including our website, that if you have questions or if your patients have questions, you can point them towards and provide that information to them as well. So I'm going to stop there. And I did just want to remind everyone. I'll put in the chat for our alerts and e-newsletters. If you have not signed up for that yet, you are able to. Okay. So I'm opening it up to questions, and I am just looking at the chat right now. And so, yes, you are correct. Arexvy and Abrysvo, I am so sorry. That is my mistake. You are correct. So Arexvy was the product from last year that was approved last year for older adults. And Abrysvo this year is approved for older adults, but also for pregnant individuals. Okay. Just looking at some other questions. When are infant doses covered by MLHU going to be available for primary care? Is that referring to RSV? Because influenza and COVID are available on, yes, RSV. So all are now available on FOSS, so that should be available now. RSV, we were having issues where with distribution, because it's a new product, we're just working out the kinks in the supply chain, where we received the higher dose. So there is a weight-based dosing for RSV. So you do need to know the individual's weight. The higher dose had arrived to us, but not the lower dose. And considering most newborns are not over 20 pounds, we really wanted to make sure that we had the lower dose available. And so, yes, we have not been able to order Beyfortus from MLHU. When will this be available? If it's not on FOSS as of today, it will be shortly, because I do know we have now received that shipment. So it should be available imminently. Okay. Any other questions?
That was very thorough and exactly the information that the network needed. Joanne, thank you so much for sharing all of that. I'm just looking to see if we have any hands up. Oh,
I do see one other question pop in the chat. Yeah. How will the hospital notify primary care providers whether a newborn had the RSV vaccine? I believe, unfortunately, it's going to be like a paper copy that they provide to the individual, like the yellow card or something like that, because of the fact that we don't have, a provincial vaccine registry.
Here's another question.
So for pneumococcal questions, so first of all, and so I actually can't answer this completely because I'll admit I have in the back of my head some of the products mixed up, but there had been some messaging earlier on around the fact that certain people who had been vaccinated with Pneumovax previously are not eligible to get the updated vaccine, and that has now, the province has clarified and said that they are actually approved. So they may actually be able to. I'd ask that you look online. We have updated that on our website to make that clear.
I just want to state the question for those that watch the recording, because I'm not sure that they'll see the question in chat. So the question was pneumococcal question. Some adults who already had Pneumovax are wondering if they can also have Prevnar 20 and pay for it. And so thank you for your answer on that.
And then there's a question here around, it's only babies born after November 1st. And again, I think that's referring to RSV. I'm not sure if that's referring to who the hospital will be vaccinating. I believe they are willing to vaccinate those who were born earlier. The cutoff, and again, the province wasn't really clear about this. They said individuals who are under the age of 12 months, or I think they actually said 8 months before the RSV season. And so we've basically set a cutoff of they need to be born in 2024. Anyone born in 2024 is eligible for an RSV vaccine. And I believe the hospital, the outpatient clinic, is willing to provide vaccination, but again, only to those who don't have a healthcare provider. Okay, I'm receiving RSV from LHSC. I was not aware of that, that they're setting a date of November 1st onwards, but I will clarify that. No, you will be able, so the question is, will we have to order Beyfortus individually? I have heard this. No, you are able to batch order in whatever amount of doses. You will be able to do that on our FOSS system. I have heard that other public health units are moving this way, but there is certainly no requirement on our end to do that. And so we have decided to allow batch ordering.
Okay, last chance for questions. All right, well, I guess that'll be a wrap, and we'll give everybody a little bit of time left in their evening, what's turned out to be a much milder fall evening than the day started out. But thank you, Dr. Kearon, for joining us, and Dr. Vineet Nair, one of our co-chairs, who is just a little raspy today, so he's letting me do the talking. And thanks to Delia here, who is our support, who wants to remain off camera. Oh, did we have another question come in here? Nope, just thanks. Okay, wonderful. Well, thank you so much for that information. Those, if you're watching on the recording, we know a significant number of people in our network do that. Please be sure to subscribe to our newsletter if you haven't already, as we mentioned at the beginning. And yeah, stay safe out there.